Hello, Assalamu alaikum. Good evening, everyone. How are you guys doing? Hello. So we have Iman, Faiza, Amra, Shaista. How are you guys doing? Mariam.
Hello, Dr. Zaib. Fine.
Hi, hi. Okay, that's great. Okay. So today we are going to discuss the another the session for this prep hour, and this is the breaking bad news. Okay, so in general we are going to talk a lot in terms of that how we are going to break the news, and of course the things are going to be the same what we have been talking in our previous sessions as well. So yes, in this session we are going to the talk little bit more in depth of the breaking bad news. So first of all, I would like to talk about that what exactly is breaking bad news, and then we are going to rehearse, on the different, the scenarios in which we need to do the breaking bad news. Okay, and we are going to talk about the different and the important scenarios of the exams as well. So let's get started with because we have to cover a lot in this the small amount of time. So I will try to discuss whatever is possible. So we have discussed last time that we have to use the spikes protocol, right, for the breaking bad news. So spike is what the setting. Setting means that you are the making the scene, or you are giving the enough privacy to the patient, or the any the family member if there is any. Okay, so you have to establish the right setting. You have to allocate the adequate time for the encounter. You have to tell him or her whatever it is. Okay, so you have to bring her to the calm and quiet room. Okay, you have to sit with her, you have to turn off your phone, you have to listen to her, you have to give her your time, and you have to listen to her as well. Then perception. Find out what the patient's perception and understanding of his or her condition is. At the same time, you have to pay attention to the patient's word as well. It's not all the time that you have to speak, and you just have to deliver whatever is in your mind. But for the breaking bad news, all you need is that you have to listen to the patient first, and then you have to give her, the whatever you want to give her the knowledge in terms of, the news itself, and then of course the management part comes in that too. Then invitation. The third thing of the spike is going to be the invite. Okay. So obtain a clear invitation by the patient to give the information. If patient is ready to take the information, if patient is ready to absorb, whatever you want to give her the news in, so of course you are going to give her, the detail. Likewise, if we do have, these so many things. Okay, this I come across in many of my sessions as well, that the candidates, they do try to deliver whatever they know. Okay, so always remember, we don't have to give the complete set of information in one setting. Okay, so we just need to be sure of that, what exactly the role player wants. So you can simply ask about that, are you the sort of the person who wants all the details on their condition, or that's just the relative one or the important one. So this is how you can save your time. Okay, but rather the talking, there's so many things in one station. So I think this is practically impossible to finish task in the 10 minutes time. So the knowledge. So you have to use the patient's current understanding of her condition as well. So what exactly does she know, what she knows about the medical facts as well. Okay, so you need to use the jargon free language. Okay, you have to come to at that level where you are going to speak with the woman, where you are going to deliver the news to her as well. So be empathic. Okay, so this is a very the important thing, in which you have to show yourself as a good doctor as well. Be empathic, please. Okay, so at the same time, while you are listening to her story, or while you are talking to her and you feel that she is crying, okay, give her time. Give her time. Ask her, would you like me to stop over here, or would you like to set another the meeting to discuss the possible management options for you? Or in any words, what you want to give. If she starts crying, okay, so give her time. Show it from your the body language, from your the facial expressions as well, that you feel bad for her. You can tell in that, in so many sentences there is, you can tell her that this must be very hard for you, Elizabeth. I understand that this has come to you as a shock. I can very well understand that this was not the result what you were hoping for. But I'm afraid, I'm so sorry to be the bearer of this news that this is the, the histopathology report, or this is the ultrasound report, is it? Okay. And then you can say that, so would you like me to go ahead with the management options, or would you like me to stop over here? So certainly, this cessation, if at all it is for the IUFT, if it is for any congenital anomaly, if it is for any of the bad news there is, so she would definitely need some of the answers that why this has happened, why me. Okay, if patient is asking why me, doctor, and she's crying at the same time, and this happens in our real life as well, isn't it? Why me, doctor? Why me? Why this has happened to me exclusively? Listen to her. Don't tell her, not in so many words, and I will come to the example in a while. So then afterwards you have to explain the strategy, how you are going to treat her, how you are going to manage her, answer her questions, negotiate. Okay, give her the patient information leaflets, give her emergency contact numbers, give her the support groups details as well. So it is very much important that the breaking bad news should be in the steps. Okay, you should follow the some of the the basic ethical principles along with your the medical principles as well. For example, you don't have to interrupt if somebody is the talking. Okay, if she is talking and if she is telling you the story which is irrelevant to this case, then only in that scenario you can interrupt. Okay, don't assume. Don't assume as well. Don't just assume that, okay, I assume that the patient knew this report already, I assume that the patient had already enough information for this. No. And plus, blunt disclosure, never do that. Okay, there should not be any the blunt disclosure at all. For example, and I will give you the example as well, that what you don't need to do at all, medical jargons, avoid medical jargons as much as possible. And the and destroying hope as well. For example, for the case of cancer patients, they usually ask, do you think that this is the end of my life? And this really happens in exam. In my real exam, I had the one of the station, it was, I think, complex, the hyperplasia, okay, or atypical hyperplasia. And when I gave her the news, and of course she started crying, she was pretty young. And then in the end she said, so it means this is the end of my life. So it means that it is going to turn into cancer anytime, so it means I cannot be a mother at all. Okay, so at that time you cannot tell her that, yes, you cannot be like this. Okay, yes, because you had some of the positive risk factors, so yes, you were the ideal candidate for development of cancer. So yes, the because you have developed this thing, so yes, the chances of survival are very less, until unless this is stage 4, until unless this is stage 3 cancer, more or less. Sometimes this happens in the cancer scenarios. Okay, so don't just destroy the hope. You can simply say that the prognosis of the cancer can depend on many things. There is, okay, your general well-being, your the risk factors if you have any, your past medical and the surgical record, your current the health situation. Plus we need to find out that what exactly is the stage and the grade of the cancer is. Then only we can tell you that what is going to be the survival. Then so roughly you can tell her about the survival rates. What I'm sure in that the particular exam time, nobody can remember the exact percentages or figures, but just they give her the kind of the you can say the vague the terms. Okay, you can say, okay, 60 out of 100 women if it is the stage 1, or if it is the for the C endometrium, we know roughly that the stage 1 has very good prognosis, stage 2 has the little less than stage 1, and then so and so. Ovarian carcinoma, because they diagnosed quite late in their staging, so of course they have the very poor prognosis. But of course you don't have to kill the patient in the same sitting that she will go outside your clinic and she will just the go, or she will just the lose hope, or she will just try to kill herself or harm herself in any way there is. Okay, so don't ignore the patient input. If patient wants to give you any of the details, so do try to give the take those clues as well. Do try to the bring that knowledge into your management part as well. Okay, so this spikes protocol is very much important. So all the time when you are thinking about the breaking bad news station, so always think that okay, but not in so many words. You have to tell the verbally that okay, I'll be giving you breaking bad news by doing the spikes protocol. No, this is for you. This is for your the rehearsal in your mind. Okay, so always think while you are standing outside that okay, so I have to do this. Okay, so I have to follow this kind of protocol. So always remember you have to deliver the bad news gradually and let the patient know that what exactly is the reason and why this has happened. Take time to express your sorrow and empathy with the statements such as, the I'm so sorry that this has happened to you. I'm so sorry that, that I've been the bearer of this news. I'm so, and this should look from your face as well at the same time. Okay, you shouldn't be like masked fish. You can, if even if it is online exam, you can even little bit lean forward. Okay, you can, the put your hand on the, the table if you are, the sitting in your study desk. Okay, so you can put your arm on the desk and you can little bit lean forward and you can just be little close to as close. Even in the, the face-to-face exam, you can okay. Don't try to touch the patient. Okay, don't try to touch the role player. Okay, but just you can show your sympathy from your body posture, from your facial expressions and all. Okay, so of course the this will show that that you are a good doctor. You are showing empathy, you are showing compassion, and you are offering her support as well. That of course she'll be able to listen to you afterwards if you want to talk about the management part. So remember, all patients who suffer tragic losses of their babies and whose babies have serious or lethal anomalies, or who receive news about their health, such as diagnosis of cancer, need to have the best possible care and support. Yeah. So warning shots are very much necessary. Okay, so I'm afraid I don't have a very good news. Are you on your own today? Are you here, the alone to discuss the biopsy result, Mrs. Elizabeth? Yes, doctor. Oh, what is it? I'm so sorry that, I'm afraid I don't have a very good news to tell you. Oh, what happened, doctor? What exactly has happened? Okay, so this is how, you at least when you are going to take, the small pauses. So of course, patient will understand that something bad is coming up. Okay, so it should not be like, I mean, in a way that you are, exploding a bomb. Okay, that okay, the result is with me and it shows that you have cancer. Oh my god, cancer. I'm i'm afraid that in that scenario she won't be able to even speak to you later on. So this is very much important that how good your communication skills are. So good communication skill is essential. You must be mindful of your tone. You have to express genuine concern. And how do we express genuine concern? Of course, from our expressions. Of course, from our the body language as well. So be sensitive, be non-judgmental, use warm, open body language, and maintain eye contact while providing your information to them. Okay, so use simple language, encourage patient to ask question. Sometimes the patient may be shocked, and this happens. So they may feel shocked and find the difficult to understand the information or think clearly as well. So that's why it is very much imperative that you don't give a lot of information in one setting. Okay, you can simply tell her that okay, this has happened, and now what we are going to do is that I'm going to send you to the group of specialists who are going to run some the further test on you. You can give the slight idea what type of test that can be, and then you can go. So it's not necessary that you have to talk about each and everything in one setting. So avoid some of the statements. Okay, avoid statements like miscarriage is very common. Okay, so at least you have the other children as well, isn't it? So what if that this has miscarried? This will show such of insensitivity that I think this is not going to help you at all. Avoid saying that this is not the end of the world, Elizabeth. So what if that has happened? Never say that. Loss for any person, for anything whatsoever, is a loss. Okay, you don't know what is the loss for me. I don't know what exactly is the meaning of loss for you. Okay, but as a doctor we know that losing a family member, losing a child, losing parents, okay, or getting, the any bad news for such, the close relatives, or you can say the blood relations. So this is going to be, the very, the tricky. So avoid saying that, in terms of this has happened with me, okay. So these are all, the real life examples. What do I hear, on day-to-day basis? So avoid saying that as your family history was positive for cancers, so you were the likely candidate to have the cancer. I'm sorry, this is not good at all. Okay, so never say that because your family had, the family history is positive of cancers. So yes, it was bound to happen that you had to have, this cancer. Never say that. Avoid using your baby is dead in the uterus, Elizabeth. Okay, I'm sorry. This is again is going to be very insensitive. Okay, so at least create some scenes first and prepare the patient. For IUFT, at least, you have to be very, the kind of sensitive. You can simply ask, the history little bit before giving her, this bad news. Okay, until and unless she's asking again and again, again and again, no, 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 tell me about the news, tell me about the news, tell me about the ultrasound. Okay, in that scenario, then you can choose, some of the good sentences. But in this scenario, you can simply ask her that, okay, Elizabeth, can you tell me that, how far are you in your pregnancy? Yes, doctor, 34 weeks. Okay. And how has been baby kicking? Yes, doctor, but, I had some kind of, the decrease, the baby kicking for the last 1 week. So I was, the coming back and forth. But since last night, I could not appreciate. See, now you are, the having background information that how you are going to give her the news in that setting. You can simply, later on you can use the given information as your tool to give her information. Okay, so later on, of course, you have to give, this your impression of report into your medical record. So staff or the clinician, the whoever will come and, they take the job role. So, they will come to know that what exactly has happened and what is going to be the future interaction. So of course, this everything is going to be in the patient's record. So don't the use all these statements. So I hope now, because I have, this is I think second session where I'm repeating the same stuff regarding this, that you have to avoid, the certain, the sentences. So I hope this is going to be helpful for all of you. Okay, clear everyone? Mm-hmm. Okay, very good. Okay, very good, very good. That's great. Good job, good job. Okay, so be extremely careful. So the possible task in the breaking bad news, what exactly they could be? Sometimes, of course, and most of the time, it can be the congenital anomalies on the scans, anencephaly, congenital diaphragmatic hernia, holoprosencephaly, gastroschisis, omphalocele, hydrocephalus, talipes, cleft lip, cleft palate, spina bifida. Chromosomal abnormalities such as Down syndrome, Atwood syndrome, Tau syndrome, and you can even add, the increased knuckle thickness as well. Okay, because this as the alone can come as, because it is the part of some of the chromosomal abnormalities. Then there can be histopathological report of carcinoma, then it can be the miscarriage on the scan, then it can be the IUFT, very tricky one, isn't it? So while you have to talk about the IUFT, so things are going to be very tricky in that scenario. Okay, so keeping in view of all these, the breaking bad news scenario, so I need all of you to volunteer yourself. And now one by one, you are going to tell me that how you are going to break the news of anencephaly. Anyone?
Yes, Dr. Zaib.
Mm-hmm. Yes,
I
Iman?
yes, I will. If she permit me to ask her first about the medical history and the history of the current pregnancy, and I will ask her also if she knows about the report or any idea about the report or not. If not, and after finishing the history and the history of the current pregnancy and the history of and the past history medically, surgically, and family history and support and everything, I will tell her now I can tell you about the ultrasound report. And I am sorry you are here alone today. If you want somebody to accompany you during this, to give you this information, and I'm sorry the result of the ultrasound is not as we are expecting, and I'm sorry I'm the barrier of this news. Then when she will tell me, please tell me what is in the report, I will tell her that the baby is not developed as we are expecting. You know, the development of the skull and the brain, it reached to a stages during the development of the baby inside the womb. But I'm sorry to tell you that the development of the bone skull of the baby and also the brain is defective or is not normal. It is the skull or the bone of the skull of the baby is not developed, and also the brain is not developed well, and we name this condition is anencephaly. And it is not compatible with life. The baby, if when the baby will be delivered, maybe he will not live after delivery, and also maybe he will die inside the womb. And you have the choice to terminate this pregnancy or to continue. It is your decision to take. And if she asks me about what is the causes, I will tell her this is kind of congenital abnormality. It happens when the brain or the spinal cord doesn't develop with the baby, and the reason for this may be sometimes we're not clear about all the causes, but we can maybe the deficiency of the folic acid, maybe according to some genetic factors with the mother, and we must do some investigation after the delivery of this baby to know more about what is the causes of this abnormality.
Okay.
Yeah.
So everyone, is it okay for anencephaly? Yes. Do you think that it is the the good news, or the kind of the bad news in terms of that anencephaly? How you are going to break this news? Everyone, what are your thoughts about it? Nobody wants to take part, so me and Iman, we are going to discuss. Okay, so Iman, okay, so if I just ask you that, how you are going to describe an anencephaly, how you are going to do that?
Anencephaly, it is the brain and the bony part of the head is not developed, and because of genetic problem, or because deficiency in the folic acid, like it is a spina bifida, part of a spina bifida, as any deficiency in the central nervous system or the spinal cord. Um,
So, if you really want to talk about that, how you are going to explain and carefully to the patient. So you are going to say, in very simple language. Okay, you are not going to go into the causes right away. You are going to tell her that, hello, after, the giving warning shots and all. So you're going to say that, your ultrasound report is with me and it shows that you are pregnant and your baby is having an anencephaly. Have you ever heard about it? No, doctor. What exactly it is? So anencephaly happens when bones of the skulls do not form properly. Okay, bones of the skulls do not form properly, results in severe damage to the baby's brain. When brain is developing, and it happens in the first 24 days of the fertilization. So you can simply say that it's a condition. Where baby lacks the bony cover of the head. Okay, and this body cover protects the baby's brain from the damage inside the bone. Are you with me? And I'm so sorry that this is considered to be a very serious abnormality, and this is not even compatible with life. Your baby may die in the womb or right after the birth as well. Stop. Okay, there and then. Give her time to absorb things. Okay, give her, of course, then she is going to ask that why this has happened. So what is the reason? Now what is going to do? What are you going to do? What if I want to continue the pregnancy? What will happen at the time of delivery? What is going to happen in my next pregnancy? So there are going to be the many questions then. So of course, the breaking bad news is only for particular that situation, okay, that condition. Okay, so this is how you are going to say that the baby lacks bony cover of the head, which protects the brain inside the womb, or you can say that which protects the brain simply. Okay, so vault, which is the calvaria, which is the protecting the brain all the time. Okay, so rather than going into the causes at the same time, and the giving her all the information that okay, this is why and carefully happens and this and that. So yes, that is part of your station later on, but not the news itself. So the explanation of that particular condition should be very clear. Okay, Iman.
yes, yes, Dr. Z.
Okay, okay. Okay, good. So, who is going to tell me that how you are going to break the news regarding congenital diaphragmatic hernia? Anyone?
If nobody, I will. Oh, I will do. If
Mm-hmm.
nobody,
Yes, who is this?
Ma'am, I will.
Yes, yes, please, Faiza. Hmm.
Okay. So can I like assume a name of the patient?
Yes, yes, yes. Assume, make story. This is what we do all the time, isn't it?
Okay, I will name her as Sarah.
Okay, fine.
Okay. Hi, I'm Dr. Faiza, one of the doctors in the antenatal clinic today. May I confirm your name and age, please?
Yes, I'm Sarah.
Okay. And you would like to be addressed as?
Sarah is fine, doctor.
Okay, Sarah, I understand that you had your MIG pregnancy detailed ultrasound done today, and you are here to discuss your report. Is that right?
Yes, yes, doctor.
Okay, Sarah, I can see that you are alone here today. Is someone accompanying you, or would you like to call someone to be with you, as I have got a concerning news?
No, doctor, I'm alone. I'm on my own today. What happened?
Sarah, I'm really sorry to be bearer of this news for you, but your ultrasound scan, it has showed that there is some structural problem in the baby, okay, which we call as congenital diaphragmatic hernia. Have you heard about it before?
No, doctor.
Okay, let me explain it for you, Sarah. So what happens is that in order to keep the organs in your chest and your tummy, there is a thin sheet of muscles in between, okay, which we call as diaphragm. In your baby, what happened is that there was a hole was detected by the radiologist, okay, which we basically call as a diaphragmatic hernia. So what happens is, am I clear so far?
Yes, yes, doctor, I'm with you.
So through this hole, what happens is that the abdominal organs, your baby's stomach, liver, okay, and sometimes the bowel can move up into the chest, okay, which is not its normal place to be. So the organs in the chest, like your heart and your lungs, their functioning can be severely affected by this disorder, okay. Sometimes what happens is that the lungs, they might not be able to develop properly, and sometimes the heart functioning can be compromised, or heart can be pushed to the opposite side as well. Are you with me?
Yes, yes, doctor. Yes.
Okay. So sometimes what happens is that if might be a single structural problem with the baby, in that case, the prognosis is quite well. But sometimes it might be associated with other structural problems as well as some problems with the baby's genes, okay? So to look into it, we will have to refer you to a specialist, which we call as fetal medicine specialist, who is going to do a detailed scan of the baby again, okay? And if other abnormalities are detected, or even not, if you want to know the reason of this defect, then we can offer you, the fetal medicine specialist, in fact, can offer you some needle testing as well, so as to check the chromosomes of the baby.
Okay, okay. Fine, Faiza. Okay, so partly good. Okay, in terms of that, you know, how you are going to, first of all, you have to explain about a little bit of diaphragm. So you did good in that. And then, you know, the hernia is, or you can say that when, the organ, the moves from its normal place, we call it as hernia, or it can come out through any kind of hole or the defect in the body. It is termed as hernia. So in this, what happens is that, yes, the diaphragm is, the sheet of the muscles. So you can simply start with that, the diaphragm is a sheet of the muscles which separate the, the chest from the tummy. Okay. And this congenital diaphragmatic hernia happens when there is going to be a hole in the, that diaphragm. So what will happen is the content of the tummy will, migrate into the thorax and chest, you can say in the chest, or it is going to compress the, the lungs and the heart. So then in the consequences, so patient is going to ask that, why this has happened. So in terms of this, you did good, not bad. Okay. So
Okay, ma'am. Thank you.
Good. Okay, so holoprosencephaly. Who is going to tell me that how you are going to explain? Not in so many words, management or something, because in one, two lines, we just have to break the news for everything. What is holoprosencephaly?
Can I, doctor?
Oh yeah, sure.
Okay, can I start?
Yes, yes, yes.
Okay, hello, I'm Dr. Amira Al-Asmar, and the ST5 in the clinic today. Can you confirm my name and age, please?
Yes, I'm Sarah, and I'm 26 years.
What do you want me to address you?
Sarah is fine.
Okay, so I understand from your notes that you are coming today because you did a scan and you want to know about the result. Is that right?
Yes, doctor.
Okay, Sarah, I'm after confirming your name and the NH hostel number. So I'm afraid I don't have a very good news for you. That the scan shows that the baby may have anomalies in some abnormalities in his brain, in some midline defects, structural defects, and some anomalies that may be incompatible with life.
Okay, so what exactly it is?
Sorry, Sarah?
So what exactly it is?
It's a condition that called the holoprosencephaly. Did you hear about it before?
No.
Okay, Sarah, do you want someone to be attended with you?
No.
Okay, Sarah. Are you fine to continue the consultation?
Yes, yes.
Okay, Sarah, this structural defect may be incompatible with life, that the baby may die inside your womb or after birth. I'm so sorry to tell you that. but it's related to the genetic makeup of the baby that we inherited from our parents. So they may have some abnormalities in the number of the genes, and so have these birth defects. Am I clear so far?
Yes, yes, doctor. So, I mean, what will happen to the baby?
As I told you, that the baby may die inside your womb, or may die shortly after birth. So the decision to terminate the pregnancy or to continue is your decision. After discussion with your partner, your family, you make the decision to continue this pregnancy or to terminate it. What do you think about that?
Okay, okay, I will think, doctor.
Okay, I will arrange another appointment with my consultant, and I'll provide you with the patient information leaflets. You can know more about your condition, and I will give you some contact numbers to support group. And I'm so sorry to tell you, Sarah, hoping you are fine now.
Okay, okay.
Okay,
Fine.
so
Okay, Amira. So, in terms of BBN, okay, forget about the steps. So, how about the explanation of the holoprosencephaly?
sorry?
So, how about the explanation of holoprosencephaly? Do you think that you did right? Correct?
No.
Okay, well, that's very honest answer. Well, okay. So, yeah, the following the steps is okay. So, how you are going to tell her about the holoprosencephaly? So, of course, you are going to give her, the some of the thing that your, the baby has a very, the major abnormality involving the development of the brain. We call it as holoprosencephaly. Okay. So, one, the kind of, the shot. Okay, so your baby has a the major abnormality with the development of the brain. We call it as holoprosencephaly. Have you ever heard about it? No, doctor. No. What exactly is it? Then you are going to first tell her about the normality, and then you are going to tell her about your abnormality. Then you are going to tell her that, look, Sarah, what happens is that normally our brain is divided into the two halves, and we call it as hemisphere. Okay, so normally when baby is developing in the womb, so what happens is that brain is going to be the developed in the two halves. We call it as right hemisphere and the left hemisphere. But in holoprosencephaly, what happens is that baby is not, the baby's brain is not going to be divided into two halves. So it will convert into one half. So it will be termed as the holoprosencephaly. And I'm afraid that this is not even going to be compatible with life. Okay, so Claire, Amra?
Doctor, sure. Yes.
Okay, so then of course you are going to go into the causes, that why this happens and this and that. But of course, the first you have to be very specific regarding the term what you are using. Okay, so first you have to tell her clearly what exactly has happened, like an encephaly, like congenital diaphragmatic hernia. Okay, if it is a serious lethal abnormality, so you are going to tell her in your opening statement that this is a the major the developmental defect or the major abnormality. Okay, or the anything, or we call it as the lethal abnormality, and this is not this is not going to be compatible with life as well. All right, so the holoprosencephaly, of course, this is going to be the unihemisphere. So as a rule, this is not going to be compatible with life. Then of course we are going to go into the depth that with the which syndrome it is going to be associated with. So more likely this is going to be the Tau syndrome. Okay, so of course we're not talking about that, but the holoprosencephaly, first you have to tell about the holoprosencephaly. Clear, everyone? Faiza, Iman, Claire?
Clear, Dr. Zaib. Clear.
Okay, okay, great, sweetheart. Okay, good. So gastroschisis and omphalocele. Who is going to give me the explanation of this? Just BBN, okay? Not completely that how you are going to explain what exactly the gastroschisis is and what exactly the omphalocele is.
Okay, Dr. Zaib, can I?
Oh yeah, sure, please.
Okay, so the patient name is like Sarah. Sarah, I understand that you have undergone your bed anomaly scan, and you are here to discuss about the report. Am I right?
Yes, yes.
Okay, so Sarah, the ultrasound doctor has some concerns about your report. Do you have anyone else with you who can accompany you? Because I would be giving a lot of information.
No, doctor.
Okay, so it's okay. I'll continue.
Yes, please.
So Sarah, this ultrasound shows that your baby has a defect in the tummy wall, through this defect, the organs of the baby, which normally are supposed to be inside the tummy, they are exposed outside in the baby's water. And this term is known as gastroschisis. Have you ever heard about it?
No, doctor. No.
Okay, so Sarah, as far as now the ultrasound, it shows only this defect that is in the tummy of the baby, and the organs like the intestines and liver, they are exposed into the baby's water. But
Shazia, you're breaking up. I can't hear you.
And to know more about if baby has any other problems, you need a scan from a specialized doctors that we call as fetal-maternal medicine specialist.
Okay.
In other case, if she has an omphalocele, then we would say that it would be a defect in the tummy of the baby. The organs are lying outside the tummy, but they are covered with a membrane. And
Okay.
similar, if it needs to be, the other anomalies need to be ruled out along with it. So you need a more detailed scan with some specialized group of doctors, and accordingly, they may offer you some more tests like needle test, or they may go for to monitor the growth of your baby. You may need more scans for that.
Okay. Okay. Well, in a way, it is good. Okay, not that bad. So, of course, like I said earlier, that first we have to talk a little bit of normality, and then we have to talk about the abnormality. So you can simply say that normally what happens is that the tummy has the all organs, like the liver, intestine, the stomach, and the spleen. So all are supported, and they all are protected by the tummy wall. Okay. So, but in gastroschisis, what happens is that, due to one or the other reasons, a defect happens, and by which, the tummy, the content, and in gastroschisis, mostly it is going to be the intestine, which are going to be free floating in the, water around the baby. Okay. With omphalocele, of course, it is going to be protected with the, the sac. Okay. The, what you can say, the amniotic, the membrane, or you can say that, it is going to be covered by the membrane of the, the sac, or you can say that, yes, and it is going to be the second important thing what you have to tell in terms of the gastroschisis and omphalocele is that which one is central and which one is, the coming through the belly button. So which one is coming through the belly button?
From the periphery, it's the gastroschisis.
Gastroschisis. Okay, so it is going to be paraumbilical, and omphalocele is going to be from where the it will come out from the belly button, or where the umbilical cord is attached. Okay, and on omphalocele we might see that and rest yes, we are told that of course we are going to send to the fetal medicine unit and all. Okay. So remember that the first it's better to talk, according to me, it's better to talk little bit of normality, and then if you will talk about the abnormality, the things are going to be very clear to the role player that okay, what exactly it is. Okay.
Okay.
Otherwise
Thank you.
Okay. 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 So hydrocephalus. Who is going to tell me what exactly the hydrocephalus is?
Okay, Dr. Zaib, I can do.
Yes. What is hydrocephalus?
I will start from the beginning to confirm the.
No. Just tell me what exactly the
Okay.
hydrocephalus is.
Hydrocephalus, it is the secretion of the fluids, which is we name it cerebrospinal fluid, from cavities inside the head. We name it ventricles, and it is like circulation. The ventricles excrete those fluids, and it take its path and return back to the ventricles. And when there is imbalance between the secretion of this fluid and between the excretion of it, the accumulation of the fluid will be inside those cavities, or we name it ventricles, and this can cause pressure on the brain, and the brain may be damaged from this pressure of the fluids on it.
It's better not to say damage, because sometimes hydrocephalus is quite treatable if it is not, the mild, moderate, and severe. Okay, so the hydrocephalus,
Okay.
the management is going to be, and the damage to the brain is going to be upon the severity of the hydrocephalus. Okay, if I'm not wrong.
Yes.
So
Yes.
yes, hydrocephalus, yes, very good. So you have mentioned that there is going to be, the abnormally high volume of the cerebrospinal fluid. The normal, what you have to tell her about the cerebrospinal fluid, that cerebrospinal fluid is the normal fluid which acts as a cushion between the brain and the spinal cord, which is going to protect the brain and the spinal cord from the rapid movement of the the body. So normally what happens is that this fluid is going to be made, or you can say that it is going to be made and it is going to be absorbed by the brain cells. But in this one or the other reasons, because later on you have to find out the reason that why hydrocephalus has happened. Okay, so you can say that because of the one or the other reasons. Okay, either the production is more, either the absorption is less, or either there is any problem, any blockage. So with this, what happens is that the brain the makes more, brain and the spinal cord makes more amount of the cerebrospinal fluid, and that will turn, and that will become the condition what we termed as hydrocephalus. Okay, so
Okay.
yes, it was good, Iman, not bad.
Thank
Okay.
you.
Okay, good job. So yes, now comes very easy and the most important, the exam, the scenario, talipes and the cleft lip and cleft palate. So who is going to tell me how you are going to, explain talipes equinovarus?
Can I help?
Oh yeah, sure.
Yeah, so I assume the patient name is Sarah. Sarah, your report is with me, and I have confirmed your name and your NHS number, and this report belongs to you. I have a difficult news to discuss with you. Would you like someone to be with you?
No, doctor.
So, Sarah, your report shows that the baby's feet are turned inward, and they are pointed out inward and downward. And we call this condition talipes or club feet. Have you ever heard about that?
No, doctor. No.
So this is a condition, and most of the time there is no reason for this condition. But I assure you that this condition is compatible with life. And in my personal experience, I have seen many babies with this condition. But with mild physiotherapy and by some exercises, this condition can be improved. So what are your thoughts about this condition?
Okay, good. Shasta? So yes, talipes equinovarus, it comes as an exam station, and it comes as a unilateral talipes as well. It comes as the bilateral talipes as well. There is one the famous scenario of the exam in which she is asking for termination of pregnancy because she doesn't want to carry the talipes equinovarus. So that is going to be your station, that how you are going to talk about that. Okay, this is the, like she said, that this is not a lethal abnormality and this is correctable abnormality, although the correction is going to be after the birth of the baby. So we don't have any the modality or any treatment option which can treat the baby inside the womb, but yes, the treatment is available, and that is going to be after the birth of the baby. Okay, so I will say, Shaista, that while you are giving the news, don't say at the same time that in my personal experience, baby usually survive. Okay, you can reserve this sentence later on if she asks you, in terms of management. Okay, in terms of the termination, because this is an exam scenario and this comes. Okay. So, while you are giving the news, so be very straightforward, okay, be very professional to tell her that, I have a news and, concerning news, okay. And, but, your baby is having a congenital, the problem, what we call it as telephysicanovirus, in which the baby's feet are pointed inward and downward, okay. So of course she will be alarmed, she will be shocked, and you have to follow the same principles of the BBN, and then you are going to give her time and this and that, and of course in terms of management she is going to ask you, okay. So of course this is correctable if it is unilateral or if it is bilateral, so this is correctable. So you have to counsel her that, and this is your exam, that how you are going to counsel her. And she might be asking you again and again, no, 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 I don't want to keep this baby because I don't want to, the carry the handicapped baby or this and that. Okay. Then you can simply tell her, okay, take your time. Okay. Give her some information leaflets, give her support groups. Okay. Give her, the every kind of possible thing in which she can rethink, or she can, the again they give a thought about the termination of pregnancy. So yes, it is very much important. Okay, so cleft lip and cleft palate, anyone? Hmm? Anyone?
Okay,
This is not exam, okay.
okay, Dr. Zaib, if nobody want to do.
Just wait a sec, okay.
Okay.
Yes, anyone? Okay, Iman, yes, go ahead.
Okay. I will make the introduction of, or I will tell the
No,
definition.
just tell that how
Okay.
you are going
Okay.
to tell her that
Okay.
the baby has
Uh,
cleft lip and then
I,
cleft palate.
yeah. May I ask you if you want somebody with you in our discussion, because I am afraid maybe I have, may I have some difficult information to tell you. And when she will ask me what is the report result, I will tell her it is the after confirmation of your name and your birth date on the
Okay, that is
report.
done. Just tell that how you are going to explain cleft lip.
Okay. The cleft lip, the lip of the baby, the upper lip and the lower lip. The upper lip has a separation in the half, into half, instead of to be complete. It is there is a separation or division in the middle of the lip or in the part of the lip. We name it cleft lip. And this is maybe because some genetic problem, some medication, some environmental factors. We will do some investigation after you after your delivery. But the baby after the delivery, he will be normal, and he can have a surgery to correct this defect or this separation in his lip.
I mean, this is so big, isn't it? So you can simply say that, the baby's upper lip or the lower lip hasn't formed properly and it has a gap in it or it has a hole in it. Simple. Okay.
Okay.
So,
Okay.
first you have to give the specific definition of cleft lip. And likewise for the cleft palate as well. You are going to say there is a hole in the palate, or you can say that there is a gap in the palate. Okay. We call it as cleft palate. So of course,
Okay.
in afterwards you can say that palate has, the when the palate is, the being developed. So anatomically, what happens is it has two halves. So it is going to be, the united, the in the middle. Okay, and sometimes, because of the one or the other reason, the palate is not united properly. So it has a gap or it has a hole. The simply. So stay as simple as possible. So then
Okay.
only, you are going to go into the depth of that why this has happened. So but then the treatment option is going to be according to the side of the palate, the cleft, okay, and then whether it is unilateral, bilateral. For the palate, of course, this is going to be challenging. So the management is going to be according to the the and management is going to be with the help of the neonatologist. And so of course, this is not the domain at the moment. So in terms of the definition, so this is going to be the small, the simple and the crisp definition. Okay, there is a hole in the or you can say there is a gap in the the lip, cleft lip, or there is a hole or the gap in the palate as well. So simple. Okay.
Okay.
All right.
Dr. Zaib,
Mhm.
we will say the term palate or roof of the mouth.
You
What
can
we
say
must
palate
to
as,
say?
because palate is an English word. Palate is not a
Okay.
medical word as well. You can say roof of
Okay.
the mouth as well. That is
Okay.
also the okay. Okay, while you
Okay.
are if she doesn't understand palate, so in that scenario you can say this is what the roof of the mouth as well. We call it as roof of the mouth, or there is a hole in the roof of the mouth. So yes, anything.
Okay.
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 Okay, fine. Very good, everyone. So spina bifida, how we are going to, the explain?
Can I?
Yes, Samra.
Okay, it's a defect in the back of baby. It's covering the back, and so the spinal cord and its surrounding may be exposed. May lead to some abnormalities in the nerves or baby nerves. That
Mm-hmm. Mm-hmm. Nerves. Is it only nerves? No, right? So spina
yes,
bifida, first of all, you are going to describe the spina bifida. Okay, this is the type of the neural tube defect. Okay, this is a type of the neural tube defect in which there is going to be a gap in the baby's spine. So what happens is that there can be a hole or there can be a gap in the different part of the baby's spine while baby is the forming inside the womb. Okay, so we call it as spina bifida. So spina bifida, if only there is a the problem in the bones of the spines, this is going to be spina bifida occulta. This is what I'm telling you, but in real exam, of course, if it is spina bifida occulta, if it is spina bifida with hydrocele, if it is spina bifida with meningocele, if it is spina bifida with meningomyelocele, then only you are going to explain. Okay, for the simple terminologies, you can simply say that there is going to be a hole or the gap in the spine while the baby is developing, and this is the kind of the neural tube defect. Okay, so neural tube is the tube, from where the brain and the spinal cord starts developing in the womb while baby is being fertilized, after baby's the fertilization. So this is how you are going to tell, if at all you have to say about the talk about the types. So spina bifida occulta is going to be problems in the the development of the spines only, and spina bifida occulta is quite common, and it is even the many of us can be the cases of spina bifida occulta. Okay, so but yes, spina bifida, the with meningocele, if the brain matter is along with sorry, if the spinal cord, the coverings are with that, the are coming out or protruding out through that hole or the gap, it will be termed as spina bifida with meningocele. Meningomyelocele, if the brain and the spinal cord both are coming through that hole, and they are coming out through that hole, so that is going to be the spina bifida with meningomyelocele. Okay, Amira.
Okay, doctor.
Okay, that's great. Okay, then comes the chromosomal abnormality, Down syndrome, Edwards syndrome, Toss syndrome, and I'm sure that almost all of you knows that what exactly the Down syndrome is. So you have to have this Down syndrome on your tips, and usually Edwards syndrome, Toss syndrome doesn't come as a the station, but because it is also the part of the Breaking Bad news spectrum that the chromosomal abnormalities should come. Then comes histopathological report of carcinoma. For example, this is a case, like I have said, that in my exam it was the atypical hyperplasia, and the patient was 38 or 37, I believe. So how you are going to break the news? Anyone?
Okay, Dr. Zaib.
Just wait, Iman. Let's see if somebody comes up. No, then you. Okay. Okay. Anyone?
So, doctor, it would be like the biopsy you have undergone. The report has come and it shows that you have 8 abnormal cells in the lining of the womb. And right now, the next question would be like, is it a cancer? So right now, it's not a cancer, but it can develop into a cancer over a
Mhm.
period of time.
Mhm. Okay. Any other, the good terminology? Hmm?
Mm,
Okay. Anything else you would like to think of? Hmm? You can simply say that hyperplasia is a condition in which the lining of the womb grows too thick. Okay, this is hyperplasia, and it can
Yeah.
be of two type. It can be of two type. It can be simple, where the lining of the womb has grown so thick, but the architecture of the cells are also preserved. Okay, so we call it as simple hyperplasia, or the hyperplasia without atopia. But when the lining of the womb is so thick and the structure of the cells are also the distorted, or structure of the cells are also not the normal, so we call it as atypical hyperplasia. And yes, the at the moment it is not cancer, but it can turn into cancer. Okay, for of course, the then you have to, because this is going to be a difficult news, this is going to be a bad news as well for the young lady
Yeah.
who is 37, 38. Okay, so you have to follow the same steps, and you are going to to talk about the hyperplasia. Okay, what exactly the hyperplasia is, and how you are going to divide it. And then the question she asked me, I still remember, that what is going to be the treatment option. Okay, so are you going to take out my womb? Look, I haven't started my family, so so what are going to be my options to have kids? Okay, so she asked me that, and all the time you won't believe that she was crying, 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 and crying. Okay, and it was so hard for me to complete the session as well. So yes, this happens, and this is also the one of the exam scenario. So always remember hyperplasia when the lining of the the womb grows so thick, and the simple, then the structure of the cells are preserved, the structure of the cells are not abnormal. So yes, with the the passage of time, or with the help of the treatment, that can grow back to the normal. Okay, and then of course the treatment option is going to be according to the green dog guideline. If it is the
Oh,
atypical hyperplasia, then yes, you can simply the explain in one or two lines. Okay,
okay. Okay.
good, good job. All right, so Miss Garage, I think we have done last time. Okay, so 34 weeks IUFT, who's going to, and this is primipara, okay, primigravida. Who is going to break the news for IUFT?
Okay, Dr. Zaib.
Okay.
Yeah. I'm sorry, Sarah. If you want somebody to be with you in our discussion, because I'm afraid I have difficulty news to tell you. And I am
What
sorry, I
happened,
am the
doctor?
one. Yes, doctor?
What happened? What
Yes,
happened, doctor?
yes, the ultrasound report which has done shows that the fetal heart movement is stopped, and we cannot see any heart movement or heartbeat in the baby's heart.
Try again.
I'm,
Try again.
yes,
Something good. Hmm?
I'm sorry to tell you that the baby's heart stopped beating, and I'm sorry to tell you the baby is not alive because there is no heartbeat for your baby. The heartbeat is stopped. Um, we cannot see any heartbeat or any heartbeat movement in the ultrasound, and we confirm it twice with two different sonographer to be sure about it.
Okay.
I don't know if I can tell her the baby's died, or I tell
Why
her
not?
the. Okay,
You have to tell her. Okay.
okay. So I'm sorry to tell you that the babies died, and we confirm it twice to tell you this bad news. I'm sorry to be the bearer of this bad news.
Okay. Okay, good try. Anyone else would like to try?
Ma'am, may I?
Oh, yes, yes.
Okay, Sarah, I can see that you are 34 weeks into your first pregnancy and you had an ultrasound examination done today and are here to discuss the report. Is that right?
Yes, doctor.
Okay, Sarah, have you named your baby as yet?
No, doctor.
Okay, Sarah, I can see that you are alone here today. Is there someone accompanying you outside, or would you like someone to be with you till we discuss the report of your ultrasound?
No, doctor, I'm on my own. Yes, please.
Okay, Sarah, I have confirmed that this ultrasound report belongs to you by your name and NHS number. And I'm really sorry to be bearer of this bad news for you. Sarah, the sonographer has confirmed that they couldn't appreciate any movement of the baby on ultrasound. And they have found out that the baby's heart had stopped beating. So, Sarah, I'm really sorry to say that your baby has died inside your womb.
Okay, not bad. Yes, you have to set some of the scenes first, okay, that, and Iman did well as well, that even the sonographer could not appreciate the baby's movement and the baby heart as well. So I'm afraid, unfortunately, I'm so sorry to have to tell you that, the baby has died in the womb. We call it as intrauterine fetal demise. Okay. So, the first IUFT, tell about IUFT, what exactly the IUFT as well. Okay, this is intrauterine fetal demise, that, we could not appreciate the baby's movement and the baby heart, the movement as well. So we call it as intrauterine fetal death. So yes, you have to set scene, and like I said earlier, that, in the setting of IUFT, apart from, the sudden IUFT, there is going to be, the history of loss of fetal movement or decreased fetal movement or something. Then you can set your own scenarios, and then, you can bring that, the knowledge into your breaking bad news. So,
Dr. Zaib, can I ask if the patient said, I feel the movement up till now, what is our answer?
So you can simply say that, maybe, she's having pain. So you can say that many women, they perceive this. Okay. But, we have confirmed through, this, the scans, and it has been confirmed by two, the doctors. Okay. And I'm afraid that, the baby has died in the womb. So, but, and this movement, we need to, examine you again, that this can be the labor pains as well. Okay. Because, some of the time, more than half of the babies, they do deliver themselves in the 24 to 48 hours itself. Because I think what 70 to 80%, they will deliver in spontaneously between 24 to 48 hours, isn't it? So sometimes, the if IUFT is old, so of course, the patient can have, the perception of that. So you can simply tell her, by being gentle, that yes, the many women do appreciate, the movements as well, but we need to confirm it, that whether they are, the labor pains, or whether they are, the movements. But I'm afraid, this is exactly the news is, and even in that scenario, she can ask you that, what if I want to go for another scan? You can say that, so far, this is the confirmed news, but if you really want to go for that, I can arrange another scan for you. But I'm afraid this is not going to change the outcome. Okay. This is
And
not
Dr.
going to
Zaib,
change the outcome.
can we tell this is the movement of the blood inside your womb between the baby and the
No.
circulation or something like
Don't
this?
say.
Okay.
I usually don't like it, even, the in real life, the when patient comes to us, because we have to be very gentle. Okay. So, I don't think that you have to go into the detail of that. This is the blood circulation, and this is the, the uterine, what you can say, sophil or something like that. No. Don't say that. Okay.
Okay. Thank you.
Ma'am, can we
Mhm.
just ask her before breaking the bad news that why did she have this scan done?
Yes, like I said, that she must have any reason to come in the hospital. Okay, there must be history of the bleeding per vaginum. There must be history of loss of fetal movement. There must be history of the no decreased fetal movement. Okay, or maybe that she has the any mob at that time. The maybe she is GDM, maybe she is IUGR, maybe she is already on the what you can say, the growth scans. Okay, so in that
Okay.
scenario, yes, you can ask if there is no history outside, and if you just have to break the news, then you can simply ask that, Sarah, can I know that what led you to have this the ultrasound? What was the reason that you did you came for this ultrasound? Okay, because if
Okay,
you
ma'am.
remember the decreased fetal movement protocol, that the after pinard and after hand doppler, then comes the IUFT. Oh, then comes the ultrasound, but not the directly. So if a woman is coming from community setting, then yes, we have to ascertain that, okay, that she is here for ultrasound. Yes, you can ask.
Okay, ma'am.
Okay, good job, everyone. So far, not that bad. Okay, keep practicing. For the breaking bad news, always remember that how you are going to set the scenario, how you are going to break the news. Okay, this is very much important in terms of the communication, in terms of your applied clinical knowledge as well. Keep your sentences short. Keep your the history short. If it is you think that the management is going to be long, so don't try to bring your usual template. Okay, if you will miss allergy in IUFT, if you will miss allergy in omphalocele, nobody is going to mind. But if you will miss the family history of congenital diseases, personal history of congenital diseases, so yes, it is going to affect your scenario. Okay, so do try to the think about each and every station there is, and it's not necessary to bring the whole the 10 pages of template. Okay, so be extremely careful in exam as well. All right, so thank you so much. So I hope
Dr. Zaid,
it
just a
was kind of
question.
helpful. Yes.
For this atypical hyperplasia, she's seeking for fertility. You will give her oral progesterone and then you will repeat biopsy in 3 months or 6 months.
No, for atypical hyperplasia, it is 3 months rule. For
Okay,
simple hyperplasia, it is 6 months rule. Okay.
okay. Thank you.
Okay.
Dr.
Okay. Good job,
Dr.
everyone.
Zip, if
Mhm.
she said, I am smoking, I am the one who killed the baby, or I am drinking alcohol or smoke, what our answer?
What's your answer? Of course, you are going to tell her that don't blame yourself, Sarah. Okay, because IUFT has many causes, and we cannot be certain that what has led to this situation. Okay, so I will the advise you that don't blame yourself for this, because the smoking can be one of the risk factor, but it is not the sole factor. Alcohol can be one of the risk factor, but it is not the sole factor, right? Because 50% IUFT has no reason at all. All right. So of course, the IUFT final diagnosis is going to be on postmortem. So then that is the different the discussion. All right. So but if somebody is the saying again and again, this is my mistake, this is me. Of course, you will be gentle at that time. You're going to tell her that don't blame yourself, Sarah. Okay, that at so far we don't know that this was the only reason what has led to this. This can be the contributing factor, this can be one of the reason, but this is not the sole reason. Okay.
Okay, thank you. Thank you,
Okay,
Dr.
very
Zip.
good. Very good. Thank you so much, guys. Thank you so much for being here. Okay, I know the exam is approaching so near. So all the very best to all of you. Okay, practice, practice, and practice. Okay. So I hope you guys are practicing well and you guys are doing well. So all the very, very best from my side. And I'm afraid the next week is going to be the last, the session for this hour. Okay, because then I myself am quite busy in my the mocks and the some of the groups as well. So of course I will be the available on Telegram, on WhatsApp, on Facebook, wherever you guys want to reach. Okay, if anybody wants to book me for your mocks or the anything. So, and yes, don't forget that we are coming to Islamabad and we are going to have the live circuit over there, exam like rehearsal. So if anybody who is interested, so be in touch with me, med exam expert team, or anyone. Okay, and I have only hardly 2 or 3 slots for mocks. Okay, if anyone who wants to book, so please book it as early as possible. All right, so see you inshallah next week. Bye bye, take care.